Thank you very much for your attendance. I'm Philip Lipsey, and I direct the Center for the Study of Global Japan at the University of Toronto. Welcome to today's event, Changing Global Health Governance and Japan's Role. Very, very timely topic, given what's going on in the world. I would like to thank the co-sponsor of today's event, the Consulate General of Japan in Toronto, as well as Mio Otsuka, our events and program coordinator, and Daria Dumbatz and Adam Bell of the Munk School for their support of this event. Before we begin, I would like to deliver a land acknowledgement. We wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Following the panel presentations, we will have a Q&A session. Please use the built-in Q&A feature on Zoom or email csgj.monk@utoronto.ca to submit your questions. Feel free to submit your questions during or after the presentations. It won't be disruptive to the panelists. Before we turn to our panel, it is my great pleasure to introduce Consul General Sasayama Takuya, who will deliver opening remarks. Consul General Sasayama joined the Japanese Ministry of Foreign Affairs in 1988 after graduating from the University of Tokyo. He has a long and distinguished diplomatic career with postings in Mexico, Malaysia, Korea, the United States, and Canada. Among many other posts, he was also the director of the APEC Division and the First Southeast Asia Division at the Ministry of Foreign Affairs. He took up his current position as Consul General in Toronto in July 2020. Consul General, welcome. The floor is yours.
Well, very good morning for those in Japan, perhaps, and very good evening for those who are in these my time zone of vicinity. I would like to thank the Center for the Study of Global Japan for making today's event possible. My office looks forward to continue to work with the center and, of course, Professor Lipsey. When I joined the foreign minister some 30 years ago, I was sent to Cambridge for 2 years for a study. What overwhelmed me was not only the pomp and circumstances there, but also they provide most updated and state-of-the-art information with distinguished lecturers and so forth. Today, Center for the Study of Global Japan here in Toronto Munk School is going to provide another one. They have just concluded Japan Now program. One of the themes was about China. And today, you're going to have a very interesting up-to-date discussion about the pandemic. You may have questions. Where does the COVID come from? Why do you not know where it come from? Why Donald Trump created vaccine? He's supposed to be anti-people. Why WHO didn't work? Why people do not look for WHO for vaccines? And so forth. And these questions may lead to why international organization exists. Today, you have 3 very distinguished presentators here. Among others, I saw Takuma Kayo Sensei from Japan, who won the award of Santry Prize this year. As a scholar, she was recommending E.H. Carr's 20 Years of Crisis. I love that book too. As a practitioner, I would like to add Dean Acheson's Present at the Creation, which provides many useful information and historical past. So I stop here and I give the floor back to Professor Lipsey. Thank you.
Thank you very much for that kind introduction. I would like to now introduce our panel. I'll keep the introductions brief in order to maximize time for our discussion and Q&A. Our first speaker will be Takuma Kayo, who is professor of international politics at the Faculty of Law and Politics, Tokyo Metropolitan University. She's a leading Japanese expert of global health governance and its relationship with the changing international political order. She has published extensively on global health cooperation, including a recent article in Asia Pacific Review titled "Global Solidarity is Necessary to End the COVID-19 Pandemic." She'll provide an overview of global health governance in the aftermath of COVID-19 and Japan's role. She'll be followed by Tana Johnson, who is an associate professor of public affairs and political science at the University of Wisconsin-Madison. An expert on the operation and design of international institutions, she's the author of the excellent book, Organizational Progeny: Why Governments Are Losing Control Over the Proliferating Structures of Global Governance, published from Oxford University Press. She will discuss broader issues of global governance and international cooperation, drawing on her recent article in the journal International Organization titled "Ordinary Patterns in an Extraordinary Crisis: How International Relations Make Sense of the COVID-19 Pandemic." Our final speaker will be Yves Tiberghien, who is professor of political science, Konwakai Chair in Japanese Research, and director of the Center for Japanese Research at the University of British Columbia. His research specializes in comparative political economy and global economic and environmental governance, with an empirical focus on Japan, China, Korea, and Europe. His most recent book from Cambridge University Press is titled "The East Asian COVID-19 Paradox." Drawing on this very timely book, he will discuss the comparative domestic context of COVID-19 response. We look forward to your questions after the presentations. And with that, Professor Takuma, the floor is yours.
Thank you for your introduction, Professor Lipsey and Consul General Sasayama. I'm Kayo Takuma from Tokyo Metropolitan University. First, let me express my deepest appreciation for everyone who organized and prepares for this webinar. It's such a great honor for me to attend this webinar as a speaker. Thank you very much. So let me share my presentation. I hope you can see the slide. Yes. So let me start my presentation. I teach international politics at my university, as well as research global health governance with a focus of its relationship with changing the international political order. In this regard, I have been engaged in several projects, including a comparative study on regional governance and a historical project on the League of Nations Health Organizations. So today's presentation consists of 3 parts. In the first section, I will briefly explain the meaning of the global health governance from both a historical and a structural perspective. As I explain later, historically, nation states have cooperated with each other more readily. In the second section, I will examine why the international society has failed to collaborate effectively, contrary to recent outbreaks such as Ebola or the avian flu. I will explain the reason for this from various perspectives, including the aspects of the current pandemic, the US-China confrontation, and the structural problem with the current global health governance. In the third section, I will explain how we can utilize our experience from this unprecedented pandemic to help prevent or prepare for another pandemic, as well as the role of Japan in it. So let me begin with the first section, in which I will briefly explain the global health governance from both historical and structural perspective. Global health governance is one category of global governance research. Until recently, health has not been a measure or some popular issue in global governance research, while world economy, financial policy, or climate change are major issues. This is partly because health has been regarded as a domestic issue rather than a global one. However, with the rise of the newly or re-emerging infectious diseases such as avian flu, SARS, MERS, health has been redefined as as a part of a security issue. Thus, research on health governance from various perspectives, such as focusing on its structure, global health diplomacy, and global health security is increasing. The beginning of the international cooperation dates back to the 19th century when European countries suffered from a cholera outbreak, which was originally endemic in India and spread worldwide through transnational movements such as trade or colonization. The European countries, which at first managed to cope with the outbreak by improving sanitary systems and law, got to realize how crucial it was to establish some form of international framework for cooperation, which resulted in the creation of the International Sanitary Regulations in 1903 as the original version of the current international health regulations. From the end of the 19th century through the beginning of the 20th century, remarkable medical discoveries and developments occurred, such as Robert Koch's discovery of causative agents of tuberculosis or cholera, and Kiyoshi Shiga's discovery and identification of causative agents of dysentery. Accordingly, the international cooperative system developed as a framework in which nation states or researchers from various nation states cooperated for developing and sharing technologies. Actually, under the League of Nations Health Organization, which was created in 1923, experts from not only Western European countries, but also Asia and Eastern Europe gathered to engage in various cooperative initiatives, including specialized research on malaria and dysentery, standardization of vitamins, compilation of statistics on death causes, and the provision of technical support to China and Eastern Europe. International health cooperation in the early days not only had a practical implication in terms of improving health worldwide, but also had an impact on international relations at that time. First of all, it partly played a role in facilitating international relations. Countries could easily cooperate with each other on this matter, even if they were facing political tensions or engaged in direct confrontation. For example, Germany and France, which were politically in tension in the late 19th century after Franco-Prussian War, were both involved in the European health cooperation effort. Also, during World Wars, Japan stayed within the League's health cooperation framework until 1939, even after its withdrawal from the League of Nations in 1933 because of the Manchurian incident. Japan did so because it wanted to get information on infectious diseases and also prevent its isolation in international environment. Second, international health cooperation led to the development of traditional untraditional transnational relationship among experts, governments, and academia through cooperation. Actually, is the chief director of the League of Nations Health Organization. He is sitting here. Was a Polish medical doctor, and a network of experts from various regions and countries was developed under the League of Nations, which became the basis for post-war global health governance. And such features of health cooperative framework were carried over to post-war global health governance. One example was the US-USSR health cooperation during the Cold War. Researchers from the US and the USSR cooperated with each other in developing the oral polio vaccine in the late 1950s, despite the political tensions between two countries. The US and the USSR at that time were also collaborating with each other on eradication of smallpox. Based on the USSR's proposal, the WHO launched the smallpox eradication program in 1960s, to which the US was actively committed through financial and vaccine assistance. As many people, including me, may feel, the case was quite contrary to the current US-China confrontation. At that time, the WHO, which was quite neutral towards both the US and the USSR, could get support from both countries. In addition, the US and USSR enjoyed substantial benefits from cooperation, since their allied countries were suffering from polio or smallpox outbreaks, and both countries expected the virus control measures to help strengthen their respective alliance and eventually benefit their Cold War strategies. In contrast, the COVID-19 pandemic affected the entire world at the same time, driving almost all countries to adopt a my country first policy and making cooperation difficult. To make matters worse, the US and China have become so skeptical with each other that scientific cooperation has declined. In addition, the WHO's attitude has been far from neutral, which was criticized by former US President Donald Trump, whose administration announced the US withdrawal from the organization. The International Cooperative Framework for Health is now called Global Health Governance and involves various non-state actors. With a large number of actors involved, the field of health has attracted a lot of interest and resources from a wider range of actors. On the other hand, there is some competition and politics among the actors involved, and the governance system is not a simple combination of actors with a common goal, but a complex web of state and non-state actors with different interests. Even in the case of the present pandemic, developed countries are aiming to get as many vaccines as possible, while pharmaceutical companies are looking at maximizing their profits. Meanwhile, developing countries are having difficulties in procuring vaccines for their own. That's why cooperation among actors has become quite difficult. So in the next section, I will examine why international society has not efficiently cooperated in this unprecedented pandemic, while people have readily cooperated on topics as I have explained. Perhaps one reason that explains why is a feature of the virus. That is because asymptomatic patients can infect others. The virus has spread worldwide in just a short time, affecting nearly all countries simultaneously. The feature of the virus partially explains why nation states have not effectively cooperated. During a pandemic that simultaneously affected so many nation states with immense socio-economic impacts, the response became too political, as demonstrated by President Donald Trump's attitude. In February of last year, Chinese President Xi Jinping and former US President Donald Trump shared a telephone conference during which Trump stated that the US fully supports China's fight against COVID-19 and is willing to send experts to China and offer assistance in various other forms. And the Trump's friendly attitude changed significantly after the March of the last year, when the number of patients in the United States increased dramatically, causing it to become the most affected country in the world, with some criticizing the Trump administration for its poor response. Trump, who was going to have a presidential election in that autumn, and was afraid that the response to the virus would affect the election, began to call the virus the Wuhan virus, blaming China for its supposed responsibility and criticizing the WHO as too close to China. Actually, the recent outbreaks of the pandemic are closely linked to politics in both positive and negative ways. As demonstrated by this pandemic, its impact has not been limited to our health, but has also affected a multitude of other aspects, such as damaging the global economy and promoting global poverty and inequality. Dealing with such impact comprehensively requires political leadership and a response from a high level, such as the G7 summit, G20, or the UN Security Council. Actually, the UN Security Council has adopted 3 resolutions regarding public health recently, twice for HIV/AIDS and once for Ebola. For the Ebola outbreak in 2014 in Western Africa, former US President Barack Obama led in convening the World Summit, where world leaders agreed to establish the UN mission for Ebola response and provide assistance aimed at ending the pandemic as soon as possible. Political leadership and high-level initiative is crucial in responding to current outbreak or pandemic, whose impact is immense and worldwide. A close relationship between politics and pandemic has not only been positive, but also negative, as I explained in the case between China and the United States. Because its impact extends beyond health, the actors involved have increased their responses accordingly, and for leaders, a failure in response could possibly lead to the loss of political power. That's why the response to the COVID-19 became so political in a negative way. And international political environment was also unfamiliar with international solidarity. In late 2019, when the outbreak began, much time had passed since the decline of post-war or liberal international order had been pointed out by scholars. The UK had existed from the EU, and the US citizens had elected Donald Trump as their president. When the COVID-19 emerged, international community was quite unfamiliar with global solidarity. The WHO is also responsible for a lack of global cooperation in responding to the COVID-19. The WHO, as a former center of global health cooperation, was expected to correctly and rapidly evaluate the situation, provide relevant recommendations for member states, and coordinate cooperation in the battle of people with common enemy. However, the member states were disappointed with the WHO's response, which was late and politically biased, and lost confidence in organization, subsequently affecting the WHO's leadership. Another factor that has contributed to the lack of cooperation is the structural failure of the governance, global health governance, to respond to a pandemic that has spread simultaneously in the world, all over the world. The major structural problems with respect to the pandemic include an inadequate evaluation system for pandemics, WHO's lack of authority, and the political nature of the WHO Director General, most of which were pointed out in the independent panel's report issued in this May. In terms of evaluation system, diseases except influenza have just a binary evaluation criteria, that is whether they are a public health emergency of international concern, fake or not. In contrast, influenza has 6 phases of evaluation, as shown in this picture, with pandemic being the 6th phase, while a situation where where people-to-people transmission in more than 2 countries is categorized as a phase 5. It is urgently necessary to establish some adequate evaluation or recommendation criteria for all diseases. And WHO's lack of authority is also problematic. Under the current international health regulation, IHR, a member country is required to notify the WHO within 24 hours of identifying an event of concern and determining it as notifiable. However, the IHR has no clause defining the WHO's compulsory power if a member country does not fulfill a requirement. That's why the WHO cannot make a strong demand from China for information or pursue an investigation on the origin of the diseases. Another problem is the political nature of the WHO. This slide presents the current top donors for the WHO. As this chart shows, the top 6 donors contribute nearly half of the WHO's revenue. Big donors have a strong voice on governance. Thus, once the WHO's relationship with one of big donors deteriorates, the global health governance is damaged, as observed last year with Trump's announcement to withdraw from the WHO. The lack of resource coordination system was also problematic. As I already mentioned, COVID-19's remarkable feature is that unlike other recent outbreaks such as Ebola or MERS, it spread simultaneously to different world regions. As the number of victim countries was limited in the cases of Ebola and avian flu, resources such as medical equipment and medicines were readily made available by countries not impacted by them. In contrast, nearly all countries became victims of the COVID-19, causing them to scramble for access to vaccines, medical equipment, and medicine. As a result, the gap between haves and have-nots is increasing. The situation regarding vaccine access is extraordinary, as this chart shows. It is estimated that by the end of this year, wealthy countries will have 1.2 billion surplus vaccine doses, while about only around 5 to 6% of African population is currently fully vaccinated. There are about 5 options to improve the current access gap. The first option is through participation in the COVAX facility. Therefore, the efforts of the COVAX facility, which is the first ever framework for equitable supply of vaccine, is admirable since it co-finances and provides safe and effective COVID-19 vaccines, mainly to low and middle income countries. Despite these efforts, various problems became evident in the COVAX operation, such as a very rough categorization of low and middle income countries, which poses challenges to the supply of vaccines to the right recipients, and excessive dependence on the Indian-made AstraZeneca vaccine. The second option is IP waiver, which seems the most difficult to achieve since it requires a consensus among almost all the WTO member states. Even if they agree on IP waiver, it may not be possible for developing countries to manufacture the highly sophisticated mRNA vaccine on their own. The third option is the donation of surplus vaccines from developed countries. Since last year, developed countries have pledged to donate their surplus vaccines. However, only a small number of the pledged vaccines have arrived so far, and the exact time when the bulk of the pledged vaccines will arrive in developing countries is unknown. Furthermore, most of the donated vaccines were close to expiration date, and a significant proportion of donated vaccines were destroyed. In sum, donation is not a reliable solution for this problem. The fourth option is technological transfer. To ensure smooth transfer of mRNA vaccine technology, the WHO has established the WHO Technological Transfer Hub in South Africa the spring of this year. But this initiative is quite dependent on the voluntary cooperation of major pharmaceutical companies. So the most realistic way to approach this problem would be capacity building for vaccine development and manufacturing in developing countries. Actually, African countries, which now import 99% of all their vaccines, aim to reduce imports to around 40% by 2014. BioNTech and Pfizer's announcement that it will be building vaccine manufacturing facilities in Rwanda and Senegal last month is welcome news. The deal is seen as a game changer since mRNA vaccine is currently being manufactured only in the United States and Europe. Moderna also announced its plans to build mRNA manufacturing plant in Africa. It is expected to expand production locally in Africa. And the increasing gap between the haves and have-nots is giving rise to another problem. The introduction of so-called digital vaccine passport is expected to promote economic recovery, but as long as there is a large gap in vaccination rates, it would be difficult to set up a globally standardized vaccine passport. Dr. Tedros of the WHO said this September that the vaccine passport could be considered when vaccine coverage improves. However, using at this stage would fuel discrimination. Just some countries or regions have introduced a vaccine passport while others are lagging behind. Even for developed countries, their digital capacity has created a difference in introduction of digital passport. Japan, whose vaccination rate is now among the top 10, is behind other developed countries in terms of the vaccine passport. So in this way, there is a growing gap among countries in terms of not only vaccine access, but also the introduction of vaccine passport, which will lead to inequality in economic recovery. In the next section, I will examine how we can utilize our experience to help prevent or prepare for another pandemic, as well as the role of Japan in it. As I explained, international political factors such as the US-China confrontation have largely caused the international response to be less united. Among all, the US-China confrontation will continue to have an impact on the current response and the future preparedness system in various ways. Actually, some issues between US and China, such as the origin of the virus and the competence for hegemony through vaccine diplomacy, remain highly controversial. Their competence and the conflict will negatively impact the future structural reform of the global health governance. That's why the role of other countries such as Canada, Japan, Australia, or France are becoming more integral. They are expected to lead the reform of the global health architecture and facilitate negotiation among member states. Even before the COVID-19, Japan had been prioritizing global health in its foreign policy and promoting universal health coverage through both multilateral and bilateral framework. Japan's constitution does not allow the use of its military, which pushed its diplomacy to focus on human security. As a G7 member country, Japan also played a crucial role in making global health, some priority in political agenda. As I explained in the second session, dealing with public health emergency in this globalized age requires political leadership and response at a high level. From such point of view, Japan has played an important role. For example, in 2000, Japan hosted the G8 Okinawa Summit, where world leaders agreed to establish the Global Fund to fight AIDS, tuberculosis, and malaria. Japan also hosted the G8 Toyako Summit in 2008, where it was agreed to strengthen health system internationally. In the present and the post-COVID-19 era, there are various fields in which Japan's active role in health governance is expected. I'd like to propose 4 concrete roles which are expected for Japan in the current and post-COVID-19 health governance. The first is to strengthen the health system worldwide. The world realized how crucial the organized health system is for preparedness and for controlling the pandemic. Japanese government has assisted many countries in strengthening their health system and health insurance using Japan's technology, experience, and products. In Uganda, a hand washing campaign was launched in cooperation with a Japanese company that manufactures hygiene products. Japan is expected to expand such assistance further through both bilateral and multilateral channels. And the second role for Japan is to collaborate with neighboring countries in positioning its pandemic preparedness as part of security. Of course, this pandemic preparedness and response should be conducted at the global level. However, as this pandemic has demonstrated, and as I explained in this presentation, the global collaborative system is not perfect and is currently being overhauled. Thus, the importance of regional cooperation is all the more important in the post-COVID-19 era. Actually, some regions have strengthened the regional cooperative system. For example, the European Union, which has been reluctant regarding the integration in the field of health, has moved forward to establish the European Health Union, wherein the member countries can share information and cooperation in other aspects. The African Union has also strengthened its regional health cooperative system. So, from this perspective, Japan is expected to strengthen preparedness by establishing a regional cooperative system with neighboring countries. In autumn of 2020, Japanese government announced the launch of ASEAN Center for Public Health Emergency and Emerging Diseases, which is expected to serve as a basis for cooperation, cooperative vaccine development in the region. The third role expected of Japan is to continue its effort towards ensuring equitable access, equal access to vaccines. It is important to note that the equal access to vaccine is necessary not only from a humanitarian perspective, but also to bring the benefit of quicker convergence and economic recovery. In June of this year, Japan hosted the COVAX summit, which made about 800 million pledges to COVAX. Japan's fourth role is to develop vaccines for future pandemic and neglected diseases, as well as helping develop vaccine capacity building in developing countries. Japanese pharmaceutical companies have also committed to developing vaccines for neglected diseases, although the market share is limited. Japanese pharmaceutical company Eisai has cooperated with Sabin Vaccine Institute of the United States to develop a vaccine for Chagas diseases. As part of contribution to capacity building for vaccine manufacturing, I would like to introduce the effort of Japan's Global Health Innovative Technology Fund, GHIT. GHIT, which is an international public-private partnership between government of Japan, pharmaceutical companies, Bill and Melinda Gates Foundation, and the UN agency, catalyzes open innovation across the globe to accelerate product development targeting neglected diseases. Recently, GHIT invested in products for Chagas diseases, tuberculosis, and malaria. So let me conclude my presentation. Various global health problems have surfaced since the outbreak of COVID-19. Because it is international issue, solving these problems require the active commitment of nation states. However, current look at health governance reveals that the US, which has traditionally served as a leader in global health governance, is busy coping with domestic control and does not have the time and energy to lead the initiative. Under such circumstances, the active commitment of so-called middle powers is crucial so that the international community can move forward to end the pandemic as soon as possible. Specifically, Japan is expected to play an active role in strengthening the health system worldwide, fostering regional cooperative systems, providing equal access to vaccines, and capacity building for vaccine manufacturing. It's true that the health governance is somewhat politicized in nation states, but it is also a web of various actors, including non-state actors. So non-traditional and innovative partnerships are expected to play a crucial role in post-COVID-19 health governance. So yeah, that's all from my part. Thank you for your attention.
Thank you very much, Professor Takuma, for the very comprehensive and thoughtful presentation. Professor Johnson.
I'd like to pick up on some of the things that have already been mentioned in the panel so far, and also take things in a direction of thinking about global governance more generally, beyond COVID and beyond the World Health Organization. So I'd like to talk specifically about COVID as an extraordinary crisis, but one with ordinary patterns. So problems without passports is a phrase that describes challenges that disregard national borders and threaten people in many different countries. The phrase was popularized in 2009 by former United Nations Secretary General Kofi Annan, who saw issues such as pollution, weapons proliferation, and organized crime as humanity's shared enemies. To deal with these issues, Annan urged governments and the public to work through international intergovernmental organizations, or IOs. He also urged governments and the public to collaborate on collective long-term solutions and to defer to experts with specialized knowledge. In other words, Annan believed that the response to problems without passports would be multilateral, far-sighted, and apolitical. Now, the coronavirus that spread throughout the world in 2020 certainly seemed to fit Annan's definition of problems without passports. Yet, as the outbreak turned into the full-fledged COVID-19 pandemic, countries defied each prescription, producing three patterns. One pattern was a tendency to blame international organizations. More than 100 countries demanded an independent investigation into the World Health Organization's response to the disease. And even researchers and non-governmental organizations that tried to defend the organization often sounded apologetic, noting that the World Health Organization's monolithic bureaucracy makes it slow and its competing member countries make it timid. But the United States government under President Donald Trump went farthest in its blame, declaring that the organization had bungled repeatedly and cost many lives. The Trump administration announced that the US would end its role as the World Health Organization's largest financial contributor. This relates to a second pattern, a temptation to prioritize narrow or short-term interests rather than broad or long-term ones. Many public health experts decried the US government's defunding move as selfish and myopic. For instance, a former WHO official warned it would jeopardize poor countries' main lifeline. And the president of the American Medical Association declared that the Trump administration's move made finding a solution dramatically more challenging. But in indulging narrow or short-term interests, the US was hardly unique. Against the advice of the World Health Organization, approximately 80 countries restricted exports of essential medical supplies, and approximately 160 countries banned foreign travelers. A third pattern, a divided reaction to experts. Variation arose across and within countries as some government leaders and members of the public deferred to public health experts, but others contested them. For instance, many national health advisors were like-minded in recommending intense and far-reaching countermeasures, such as lockdowns or and contact tracing. But although countries such as New Zealand and South Korea readily heeded the advice, countries such as Brazil and Russia resisted. And in a sign of governments' diverging views on experts within the WHO, a UN Security Council resolution on COVID-19 stalled for months as China insisted that the resolution endorse the World Health Organization, but the United States demanded that the WHO not be mentioned at all. These three patterns, a tendency to blame international organizations, a temptation to prioritize narrow or short-term interests, and a divided reaction to experts, mean that international organizations are highly vulnerable. That's because in addition to being disparaged directly, international organizations embody the wider interests and specialized knowledge that also are being snubbed. At first glance, this situation seems puzzling. Why, while struggling in a pandemic, would governments opt to question or punish the very international organization that's supposed to guide the world's response? Since this disease is a shared threat and can't be defeated instantaneously, why aren't countries concentrating on what would be helpful for the larger global community well into the future? And why, in a crisis of public health, are any politicians or members of the public refusing to follow guidance from public health experts? The three patterns defy what Kofi Annan recommended for handling problems without passports, and international relations scholarship helps to explain why. Research on bureaucracy and institutional design examines the challenge of making international organizations accountable to member countries, but also insulated from them. Meanwhile, research on delegation and socialization exposes governments' hardships, overcoming time inconsistency and non-credible commitments. And at the same time, research on epistemic communities and anti-elitism reveals both upsides and downsides for permitting public policy to be formulated by technocratic experts. Together, these veins of international relations research show that resistance to international organizations, to broader or longer-term interests, and to experts is quite commonplace. Such resistance has never been eradicated, and without a resolute leader to overcome it, this is how the world could look. In some past crises involving global health or other international issues, the United States has played the role of a resolute leader. But recently, the United States has been less consistent in playing that role. And even though the US has been re-engaging with global governance under its new president, Joe Biden, that engagement is hardly endorsed by all of the American public. The key takeaway is that although the pandemic may be extraordinary, its political patterns are quite ordinary. Even Kofi Annan himself would probably look at the COVID crisis with dismay, but not surprise. After all, his recommendations were about how people should respond, and he was well aware of obstacles to multilateral, far-sighted, and apolitical solutions. Yet while existing international relations scholarship helps to explain these patterns from the COVID crisis, it says less about why resolute leadership wanes. It also offers relatively little policy guidance about where international organizations, with their embodiment of wider interests and specialized knowledge, go from here. This points to two open questions. The first open question is backward looking. How have current conditions resulted from ordinary patterns in international relations interacting with specific developments in domestic politics? Blaming international organizations, prioritizing narrow or short-term interests, and reacting in a divided way to experts are recurrent temptations. Yet at some times in the past, those temptations have been overcome. So what exactly is different about those times compared to today? One place to look is within the United States, which has played a pivotal historical role in maintaining order, stability, and institutions in global governance. In recent years, party polarization has reflected and fueled internal divisions in the US, where influential segments of the government and population have exhibited fatigue with global leadership and a craving to put America first. The international relations literature reveals natural aversions to international organizations, wider interests, and experts, and further attention to developments in US domestic politics could help to explain why resolute leaders step up and surmount these aversions at some points, but not others. Another place to look is the overall population of countries. Particular sentiments may be gaining traction in multiple places at the same time. For instance, populism and anti-elitism can take various forms, such as advocating folk wisdom, economic protectionism, outlying areas, unilateralism, or nationalism. But when such sentiments take hold in numerous countries concurrently, they pose a serious challenge to formal expertise, economic liberalization, cosmopolitan cores, multilateralism, and globalism. The international relations literature reveals that deferring to experts and trusting tasks to international organizations and pursuing broader or longer-term interests involve pains as well as gains. Further attention to trends in domestic politics in countries throughout the world could help to explain conditions under which people tend to fixate on the pains rather than the gains. For the practice of public policy, there may be an entry point for Japanese leadership here. Thus far, populism and anti-elitism seem to be more prevalent in the United States and parts of Europe than in Japan. Japan is a wealthy country that even before the COVID pandemic had honed its own public health system and had prioritized public health in its overseas development assistance for other countries. Therefore, while some of its peers wrestle with populism and anti-elitism, perhaps the Japanese government will be in a more stable position for taking a leadership role in global health governance. A second open question, besides the retrospective question involving domestic politics, is forward-looking and centers on international organizations. How should the performance of IOs be gauged and addressed? As mentioned earlier, international organizations are vulnerable due to all three patterns explored above. In addition to being disparaged directly, IOs embody the wider interests and specialized knowledge that also are being snubbed. Yet while existing research makes sense of the struggles of the World Health Organization and other international organizations, it offers far less guidance on what to do about those struggles. A core difficulty is that international organizations are expected to be responsive to their member countries and also strive for the greater good. As one former WHO Director General emphasized, it's not a question of what one or several governments ask you to do. We are working for humanity. Since member countries are prone to scapegoat international organizations and are conflicted on the broader or longer term interests that international organizations embody, it's untenable for IO performance assessments to be derived from governments alone. Researchers must incorporate performance assessments from a variety of non-governmental actors too. Then they can turn to two policy relevant questions. The first is when evaluations of international organizations should take place. A testable hypothesis is that evaluations of IOs are most useful if they occur at regular intervals. Pandemics and other emergencies heighten demands for performance reviews on a post hoc basis. However, conducting reviews at regular intervals would make it more likely that some reviews occur during periods of relative calm. That would afford less tense circumstances for isolating factors and actors to be thanked or blamed. Moreover, post hoc reviews might give an anomalous snapshot, whereas evaluations at regular intervals could reveal more about day-to-day operations and even uncover issues before they become emergencies. Second issue is if an international organization is found to be faltering, what should be done? Here, there are many knowledge gaps because the tools and conditions for improving IOs are still under-examined. Governments' instincts are to punish or marginalize international organizations that displease them, but it's unclear whether that actually does much good. After all, if an organization proves to be a poor performer, the knee-jerk reaction is to abandon or starve it. But a counterintuitive and potentially superior response would be to feed it. Future research would be incredibly helpful if it investigated not only reform outcomes, but also a wider variety of reform options. Here too, there may be an entry point for Japanese leadership. For example, Japan could increase voluntary financial contributions to international organizations such as the WHO. Such increases could be earmarked for disaster preparedness, program evaluation, and other important issues that have gotten short shrift in recent years. Perhaps even more wisely, increases in Japan's voluntary financial contributions could forgo earmarks altogether, enabling staff in international organizations to direct resources where they are needed most, with more flexibility in the face of shifting global conditions. The practical questions I've flagged about domestic politics as well as IO performance are crucial for the embattled World Health Organization in the COVID crisis. However, the need for answers also goes beyond the WHO to whatever global challenges lie ahead. The next crisis could involve climate change, economic inequality, nuclear proliferation, another pandemic, or something else entirely. It could be an undreamed of black swan or an obvious and looming gray rhino. But whatever the form, without a resolute leader, the next crisis is likely to produce similar patterns, negative reactions to international organizations, as well as the wider interests and expertise that IOs represent. The world has exhibited these patterns at various points in the past and will exhibit them again in the future. International relations scholarship does a fine job of explaining why those patterns recur. With more work and perhaps a more proactive role by Japan in global governance, we could also know more about how to assess and address IO performance in response. Thank you.
Thank you very much. And just as a reminder, Professor Johnson's excellent article on this topic is available open access from the Journal International Organization. So any audience members who are interested, it's highly recommended. Professor Tiberghien.
Yeah, thank you, Professor Lipsey. It's wonderful to follow Professor Takuma and Professor Johnson. There has been a great coverage of the global dimension, so I'll be short on the global and focus on the comparative domestic side. So I'll be sharing. All right. So I'll try to be quick and focus. I'll present some data, including some most updated data here. And this is derived from this short book with some updates. So clearly the world here has faced an incredible moment because on paper, this is a global pandemic of relatively limited mortality compared to the Spanish flu or even the Asian flu of 1957, the Hong Kong flu of 1968. And yet it triggered the greatest simultaneous lockdown, the deepest short-term economic recession, and the most dangerous geopolitical confrontation since the Great Depression. So how did this happen? And I will be very short on this because essentially this is about the failure of the global system. But the second question where I'm going to focus more is why did East Asian and Oceanian countries on average perform better than the rest of the world, at least in 2020 with some hardships in mid-2021. Why did also East Asian and Oceanian countries manage to deepen cooperation in 2020, despite global tensions stemming from the pandemic? These are the key summary points that will advance. So clearly COVID has generated a multi-level global crisis that involved not just health, but also economy, society, the global economic order, geopolitics, and it generated great stress as a result. It was the timing of the crisis and a lack of global coordination that made this crisis so potent. And it contrasts greatly, as mentioned earlier by Professor Takuma, with many previous cases. The US-China competition and US reluctance with global institutions at that moment in time, in 2020, has paralyzed the global response. At the national level, however, two particular variables have really helped explain the superior East Asian response on average, right, with caveats and gaps. And I'll go to the details on those. One, institutional capacity, and second, social resilience. At the regional level, the combination of existing informal networks that were partly Japan-led through WHO, but also ADB, JICA, and others, and a logic of strategic reinforcement in the face of shared uncertainties played a key role in maintaining a deepening cooperation in the region, including the signing of RCEP in the midst of the pandemic, which is counterintuitive. So I'm going to be a few seconds on the global level because it's been covered very well. Then I'll go to the national outcomes, offering some data, and then the factors, causality, and a few updates on 2021 and vaccination. So at the big level, we went from a health crisis that globalized to an economy crisis, to a social crisis and a rise in inequality, a women crisis, migrants, vulnerable crisis as well. how did all this happen? In the book, I covered the multidimensional across those, health, economy, geopolitics, security, etc. But here is one interesting book by Larry Gostin, who just had this new approach. And he said, essentially, we need a One Health approach that encompasses wet markets, animal-human interchange, land deforestation, and all this global integrated level is not done yet. Also, we must secure high security labs, and we need better global protection against gain-of-function research. And we also need better resistance to antimicrobial issue resistance, which requires coordination. For all this, and this is to complement what was just said, right? He's arguing, and he's someone who has worked a lot with WHO, etc., that the problem is not that the WHO failed in itself, right? The problem is that it's underfunded, under-empowered, under-resourced, and that it was crippled by the clash between the US and China. And it's very, very hard when the principals fight for an agency to function. So now I'm turning to the national level. And those are some, 3 columns here. Sorry for the orange here. I haven't found yet how to remove it, but I have basically measured, this is at the time of the data of after 1 year. So February 6, 2021 data, this is what's in the book. And this is mortality rate per million residents after 1 year of COVID. And there are 3 categories: high, medium, and low. And what's interesting is that the most advanced countries, those with the best health resources, mostly end up in the high category. That include the US, much of Europe, but also South America, Brazil. And the only one that's not either South America, Europe, or US is South Africa. In the medium category, we have much of the world, and we have actually also Canada and the world average. We have Russia. We have much of South Asia. We start having a bit of East Asia here with Indonesia and Philippines. And then in the low category, we find most of East Asia and Africa. And we find extremely high performance here in the first year with, the Tanzania data is not reliable, but Vietnam, Taiwan, Mongolia, Papua, Thailand, Fiji, China, having some of the best numbers, New Zealand, Singapore. And Japan being at 50 here after 1 year, but on the good side. This is the updated map as of yesterday. And we still see generally the same pattern with the high numbers being found in North America, Europe, and South America, the good numbers in Africa and Asia in general. And so that is a striking pattern, right, that we see in terms of overall cumulative mortality. Now, of course, the data is not fully reliable, right? And there's country after country where we can argue, and in some cases, we have to multiply by 3. But it doesn't fundamentally affect the broad patterns. So this is the most updated numbers, just a few points on performance. So the US is at 2,300 deaths per million. Canada is a third of this. In Europe, we have UK, France, and most of Europe in the 2000 range. Germany is 1,200. And then South Asia, India is at 300, maybe under-evaluated by half. But the rest of South Asia is actually having good numbers. Even Bangladesh and Pakistan are better than India in terms of the numbers, with the caveats. South America has the worst numbers, Peru being the #1 in the world, and Brazil at almost at 3,000. And so by contrast, these are the numbers. Those I didn't have a chance yet to update them, but I'll show the next data. But the ranking, actually, no, I just updated those, sorry. Yes, those are the most updated data as of November 16. So in East Asia, the maximum is Malaysia, followed by Mongolia, Indonesia, Philippines. But we are here at a quarter, with Indonesia, Philippines, we're at a quarter of the US and Europe. And then when you get to Japan, we're at 145. Singapore went from very low to 112, but it's still low overall. And then we still have very low number for Korea, Taiwan, Hong Kong, New Zealand, China. So this is the current picture of performance. On Japan, there's an interesting aside here, a caveat. There have been studies of excess mortality, and those excess mortality numbers show potentially that there's a lot of unexplained mortality that took place during each of the waves. We have converged back now. There's no more unexplained mortality since September, but there were big gaps potentially that have not yet been fully explained. So there's a potential undercounting in Japan as well. So to be continued, because there's no final reconciliation of those numbers with the mortality from COVID. In terms of where we have high cases right now, this is the daily new confirmed per million, smooth over 7 days. So we find actually some pretty high numbers in UK, Germany, Singapore, surprisingly, despite the high vaccination. The US is now better than a couple months ago. And then we have very low numbers in Japan, Taiwan, India, Korea, Australia, and even Canada. So this is the current situation where we are. So you find this with all those waves. The US has come down significantly, and then we're back to very low numbers for all of Asia, including Japan. So now that gets me to the puzzle. There was this very interesting exercise that was done, luckily for us, in November 2019 by Johns Hopkins University, along with the Economist Intelligence Unit and other partner, in ranking the preparation for pandemic in most countries of the world. They call this the Global Health Security Index. The number one was the US, followed by UK, followed by Canada, Australia, Netherlands. And you saw Thailand and Korea pretty high here, interestingly enough. Japan is pretty high, but a little lower here. Germany was here. So this is the expectation of who would do very well in a case of a pandemic, mostly based on structural variables like the capacity of the healthcare system and other core elements. And yet, if you cross-tabulate in 3 categories, high, medium, and low, this GHS index and the death rate, and I did this here as of February, so after 1 year, you find huge gaps. And essentially, the GHS index has poorly performed. Very, very poorly performed. So you find a few expected high performers, Thailand, Korea, Malaysia, Japan, Australia. So those one did well as expected. And then you have some super underperformers that were expected to do very well and did very poorly. Switzerland, oops, sorry about this. Switzerland, Sweden, France, USA, UK, Spain, other underperformers are here. And then you have the super achievers, those who had low capacity and yet did very, very well in the first year, Mongolia, Vietnam, and since then they have fallen down from that high level, those two here, but not all the way down to the US-Europe level. China, Nigeria, Cuba, Ethiopia, Senegal, Uruguay, Myanmar has fallen since then, but not all the way down, Pakistan and Bangladesh. And then you find some other overperformers here, medium overperformers, Singapore, New Zealand. So there's a lot of variation and a lot of puzzles in those outcomes. And the two arguments I'm presenting here is that it's about mid-level institutional capacity. That is, it's not just the healthcare system in itself, but it's particular legal preparations and other tools that were put in place in East Asia and Oceania that were ready to use. And I'm going to get to the details in a minute. So this is what mattered. And the second variable that I find useful is social cohesion, where East Asian governments were able to use to rely on high level of social cohesion and social trust in times of common peril. And it's an interesting correlation between surveys on social cohesion and social trust ex ante that put China, Singapore, Indonesia near the top alongside India, New Zealand, Australia, and the Nordic countries with the final outcomes. Across the region, citizens mostly followed social norms such as mask wearing and physical distancing. And this is also the case in Japan. So the specific factors were reliance on the general healthcare coverage for those who had it, so that gave an advantage. Second, rapid creation of centralized government task forces as early as January 2020 for most countries that could coordinate testing capacity, quarantines, border controls, isolation measures, and socioeconomic measures. And that was the big surprise, that places like Korea, Taiwan, Singapore, even Vietnam, Mongolia did this in January 2020, and Europe, US didn't, right? Japan did it only after March, after there was a legal change. Third was reliance on health scientists in key government positions and empowerment of national CDCs, which took place in Asia, had been recommended by Japan and the US, by the way, but was not followed anymore by the US, and that's the supreme irony. Fourth, use of quarantine isolation measures and degrees of rapid border controls, less, slower in Korea and Japan, but fast in the other cases. Fifth was rapid provision of tests and use of testing, except in Japan initially. Sixth was reliance on universal mask wearing. And there's interesting data here showing the correlation, etc. So Japan is strong there. Seven was use of innovative contact tracing apps in key places, China, Korea, Singapore, Taiwan, Vietnam, not in Japan, much less. And then finally, effective, precise, science-based and empowering communication from leaders to scientists, that included good examples in New Zealand, Singapore, Korea, and many others, but also in African cases, actually, but much less so in UK or US, for example. And so if you track some of those more detailed, granular indicators, you find those interesting data. So the creation of the centralized headquarter or task force with great power to coordinate all the ministries took place in China on January 25, Korea 22nd, Mongolia 19th, Taiwan 20th, Singapore 22nd, Vietnam the 30th, New Zealand the 28th, and other cases came soon after. And that was not the case in Europe and North America or India initially. When you look at mask wearing, very high percentages in those Asian countries, the reliance on science, very high in most cases. Testing, there's more variation, but Korea was particularly a leader there. So then it gets quite granular. On social cohesion, this is one survey. This is the World Value Survey that was done before the pandemic, but Trust Your Neighborhood. And what you find on top was Vietnam, Iceland, Finland, Norway, Thailand, followed by UK, a bit more of an outlier here when we look at the impact on the pandemic, China, Canada, Germany, Australia, Taiwan, Singapore, South Korea. And so those correlate very well with the performance in COVID and the support for all those measures like mask wearing. That's a post-COVID survey that asks, has there been more division after COVID? And you find that there is a sense of more divided, more division after COVID in most of Europe, and of course the US and even in Canada, and much less, much more positive in many Asian cases, except Korea and Japan, where there's a strong response on increasing divisions. And this is an ex-ante survey on confidence in government, so vertical trust. And we find, so the China and Vietnam number, of course, are not a free survey, so we have to take this with a grain of salt. We find high numbers for Philippines, Singapore, Indonesia, Kazakhstan, Norway, Taiwan, South Korea, and we go down afterwards, and the average is here. And again, that correlates with some strong measures, some strong performance during COVID. So those variables, which were not taken into account in the GHS, index, may prove to have a bigger impact or higher correlation, at least with outcomes. And then you find this ex post in the surveys. Did you feel that your government had a good role? So the Asian cases are very positive. Japan, not so, and Korea, not so. So Japan is often an outlier in quite a few of those numbers. And so here, should there have been more restrictions by the government, mandated by the government during COVID? So Japan is the absolute high numbers here, even higher than the US. But the other Asian Oceanian numbers are low, because they felt there was appropriate level of restrictions. So now I'll skip on Delta. So Delta is now most of the cases since the summer, except in South America and Philippines, by the way. It's an interesting outlier. But what we find is that the Delta impact, by spreading so much faster, has really hit this East Asian model and fragmented the East Asian model, East Asian Oceanian model, so into many subgroups. We see cases that have continued for a while to do zero COVID despite the high economy cost. And now most of them have given up on this, except China. And in reality, Taiwan has not yet opened up. New Zealand is a bit in between, but wants to open. Hong Kong, not yet. But Australia has moved out. Vietnam has moved out. Singapore is now moving in the second group to a much more open strategy beyond even aggressive containment, and is suffering some health impact on it, but has reopened its economy. Japan, I can't categorize Japan in all those comparative. It's a mitigation strategy with low government control, limited contact tracing tools, high reliance on voluntary social restriction, the 3C approach, and a strong healthcare system. And particularly in contrast to Canada, US, and Europe, what Japan did super well was the management of the elderly care homes, where there was not a lot of mortality compared to us in Canada or the US, but with less direct tools than the other East Asian cases. And then there is two kinds of Southeast Asian cases, mostly either completely overwhelmed in the summer with some stabilization after, and then some mixed result without being overwhelmed, but just struggles in Indonesia and Philippines. I think I'm over time, so I'll say that on the vaccine side, we have seen a huge bottleneck on the production side. Most production essentially has been happening in China, China, US, Europe, so extremely concentrated. And in terms of delivery of vaccines for the rest of the world, it has been either COVAX. The promises were China and COVAX. In practice, COVAX has struggled. China has delivered more, and then US started picking up on the Biden. But in terms of production, many have not succeeded. So what gives the only two that have produced enough at the global level are Pfizer on one hand, and the Chinese, the Sinovac, and to some extent the Sinopharm. Moderna has not been able to deliver as much in volume. It's only here. And Sputnik has failed essentially in Russia. So then you get the actual delivery numbers. So this is where we are. East Asia was slow. One of the puzzles is that East Asia was unable to develop a fast vaccine. The only ones that managed in the end were Vietnam and Taiwan, but they were slow and they have delayed the vaccination. It's surprising that Japan and Korea were not able to have their own vaccines. But after a very slow start and a delay in vaccination, now we see high numbers. Singapore is leading the world with 92%, and those are double vax numbers as of last night. Japan is now very high and higher, just above Canada, number one in G7. China is high. Korea is, of course, also very high at 78%. And then we see some areas that are still lagging below. But this has come up in a long way in the last 3 months. So in conclusion, COVID was a game changer because of the timing, hitting the system, the global system, just when the US and China were caught already in a trade war and a great collapse in their relationship. And so global cooperation was in crisis. The global governance partially failed due to inability of great powers to cooperate. Domestically, we observe large variation in outcomes among countries. Asian countries managed to contain the health impact beyond their ex-ante health system capacity for most. Key variables were mid-level crisis response institutions and social cohesion. But Asian countries were slow, unable to develop vaccines, and had a slow start. By the second year of COVID, the accumulating economic costs have led to the reopening of the economy and some higher health costs in Southeast Asia, Mongolia, and elsewhere. Inequality and social anger have risen in cases like Korea and Japan, despite some relatively good performance on the pure health side. Thank you very much. Mm-hmm.
Well, thank you to all three of you. That was a very comprehensive overview of some of the major issues. We have about 10 minutes left for Q&A. I do want to get to some audience questions. So I'll prioritize audience questions as they come in. So feel free to submit your questions to the panel. I'll begin with Maria Asensio's question, which is, that basically, given the political instability we see in the Japanese government, the frequent changes of prime ministers and ministers, how can Japan remain consistent in its efforts towards global health, maintain that leadership role that, well, I think all three of you really emphasized? And, does that present any difficulties at the domestic level in Japan in terms of improving its healthcare and innovation system, given that the government does seemingly go through frequent turnover? Of course, that wasn't the case under the Abe government, but recently we've seen a return to the more typical pattern of revolving door prime ministers. And so, Professor Takuma, would you like to take that question?
Yeah, thank you for the question, Mari. It's a important question. It's true that in Japan we see frequent changes in cabinets, but the importance of the global health, or Japan's commitment to global health, has been some consistency regardless of the changes of cabinet. Because of the Japan's constitution, Japan's commitment to the global issues is limited to the non-military issues, and the global health is the key to such a commitment, key channel to use as a link between Japan and the international global society. So I think that regardless of the changes of the cabinet, Japan has consistently prioritizing the global health as its diplomacy. But on the other hand, I'm afraid that, as Tana pointed out, that the domestic changes, such as the rise of populism or the rise of the anti-science movement or sentiment, will have effect in the Japan's commitment to the world problems. So I think that rather than the change of the cabinet, the changes of the domestic politics, or the increasing gap between the social fragmentation may affect the Japan's commitment or Japan's leadership in the global health governance.
Thank you. Yves, did you want to add something on that one?
Very briefly, it's in contrast to the East Asian cases, the policy response in Japan to COVID was slow, but Japan has a much stronger base to start with, healthcare and elderly care and everything, and resources. But the policy response was slow, and the tools were not in place. The tools were not on the book, right, to respond to a pandemic and to be organized, as we saw with the cruise ship, right, in Yokohama, right at the beginning, the Princess. And so I guess the public then responded with a lot of anger. And in fact, COVID is a key factor in the fall of Prime Minister Suga. Ironically, while his minister Kono managed to really ramp up vaccine at incredible speed, and they did a good job with the Olympic, there was no super spreader event. Nonetheless, the public somehow perceived the response as inadequate or insufficient, and all that anger was there, and there's still some remaining anger. And then Kishida-san was lucky to inherit just the fall of the fifth wave and the rise of vaccination. But so there is, on the domestic side, yeah, I guess the politics have limited the response to compared to what it could have been, right? Mm-hmm.
Yeah, great. So I suppose we're just about out of time. The presentations were very comprehensive, but I guess the trade-off is that we're a little bit short on time at the end here. So maybe I can turn it back to all three of you. I think you offered a variety of explanations about the variation in response domestically, or the shortcomings of the global response as well. And so, you presented some policy prescriptions, but I suppose I'm also curious what your prognosis is about have the right lessons been learned and have the right reforms been put into place at this point? And so, if a crisis does occur in the near future, can we expect a better outcome? Or are you still concerned that many of the structural factors, for example, that you pointed to remain in place, and thus we will still face some difficulties? Maybe we can go in reverse order, starting with Yves.
So we're not ready. There's critical vulnerabilities. I might just say two things. The easy part is, at least conceptually, is reforming the WHO, because there are many blueprints out there, including one that was already in this book by Osterholm, right, who is now on the Biden task force. So it's very well known that the WHO is under-resourced, under-empowered, and that its committee that makes the decision on calling for pandemic basically functions like a peer review committee and is looking for consensus. And so when they met January 22nd and 23rd, they were divided in the middle. They had no consensus, and they're only able to call the event at the end of January. And so that is fixable, right? Essentially, it's about putting a mandate to, instead of being peer review and look for certainty, have a mandate to be much more reactive and to be precautionary. So I think that this is fixable. Putting money, we're talking very small amounts here. We're talking a couple billion a year. So, increasing that should be easy. So that's the easy part, and it could be much more. There could be a rapid reaction force and all kind of things. The harder part is the US and China. So if the pandemic happened elsewhere, we may still be able to have the right resources. But currently, with the current Cold War that's brewing, if it happens in either of them, there's going to be those great tensions. And yes, there was also a particular Chinese failure. Between mid-December and January 20, the Chinese system failed, and there was slow reaction. They took 5 days to respond to WHO inquiry instead of 24 hours. They didn't give the full transparency, and that was related to a particular Chinese governance issues. So that's something else, right? How you fix that?
Great, Tana.
Well, I have a mixed reaction, some positive, some negative. I think I'm a bit positive on the World Health Organization. I think that Yves is absolutely right that there are these longstanding challenges. I do think, looking at the World Health Organization, however, there's pendulum swings that go on. And part of why the organization struggled so much in dealing with this pandemic is in some ways a product of how proactive it had been with some earlier issues like SARS, where it very much kind of tried to get ahead of things and sound a warning in a way that member governments then wanted to clip the wings of WHO staff. And so I see this as kind of a pendulum swing where the WHO at sometimes in the past has been criticized not for being a laggard, but instead for pulling the trigger at a time when member governments really didn't want that. And so there's probably an appetite now, given the rather slow response to COVID, for some member governments, if not all of them, to really encourage the WHO to be more proactive in the future. So I do think that there is a larger pendulum swing that might be happening for the WHO. Where I have some pessimism, however, is that I think that when it comes to international organizations more generally, not just the WHO, there's just not a lot of excitement among anyone to do the really unexciting but important work of doing things like disaster preparedness, program evaluation, experimentation, and so forth. And like I said, that's not specific to global health. You see that in things like climate change as well, where we're having, we just came out of negotiations and we're still talking about how we can mitigate climate change. And nobody is really talking seriously about how we're going to have to adapt to climate change. And so there's a real unwillingness, I think, throughout global governance structures to do some of that less exciting but really important work of preparing for disasters, having response systems, evaluating programs, and so forth. And that's where I feel a bit more pessimistic.
Great. Kayo-san, you have the last word.
Yeah, thank you. So I also have both negative and positive prospect for the future, handling. That at the global level, it is quite difficult to conduct some drastic reform at the global level because of the decline of multilateralism or the impact from the US-China confrontation. So you're looking at the discussion, looking at the current debate on the pandemic treaty, I cannot but be pessimistic. The prospect of the global health governance. On the other hand, that the global, health governance is multi-layered and multi-leveled with global, regional, and national, and those, those three levels are expected to mutually reinforcing with each other. So yeah, actually, since this outbreak at the regional level, the many countries have strengthened their regional cooperative system, and even at national level, many countries, including Japan, has try to strengthen the preparedness and response system at national level. Yeah, actually, Japan has a relatively control of the number of patients because of its strong health system, but there have become various problems such as lack of command system or lack of communication at the domestic level. So, Prime Minister Kishida announced to establish a command system for, responding the public health emergency. So I think that when the next pandemic occurs, nation states can react differently, I hope. Thank you very much.
Well, thank you very much. We're at the end of our time. I would like to thank our panelists for very stimulating discussion on such a timely topic, our audience for sticking with us, the Consulate General of Japan in Toronto, and of course, the staff at the Munk School for their support of this event. Thank you very much. Bye-bye.